Good evening, everyone. Hope everyone's doing well. We're going to veer back onto dentistry today fully with some aesthetics again, but anterior aesthetics. We can do it with hopefully the connection where Shiraz is a bit better than Harrow, and he can get on pretty quickly. We had a couple of questions, mostly about sort of composite stuff. But if you have any other bits as we go along, just pop them into the comments as always, and we can get going. Perfect, people getting in. Tom's here. Tom's a new regular. There we go. Bear with us, guys. Hope everyone's doing good on the Thursday. I know it's thrown everyone off. How are you, Tom? You got your FDs watching today, Tom? That's what we want. Shiraz is struggling to get in as well. Sorry, Tina. Just want Shiraz in at the moment. There we go. How you doing,
Hello,
man?
hello, Rupert. How you doing, champ? You well?
I'm good, bud. You doing okay?
Yeah, very well. Sorry, it's been a bit. Literally stepped in about 5 minutes ago, so got myself ready for this whole thing.
All good. All good. Busy day then?
Yeah, incredibly. It's a funny paradigm. You know, we've had obviously we had COVID and we've had all of that stuff, and then you've had this unrealistic and unsustainable surge that still hasn't ended, and then we've had associates moving, and then it's getting crazy. It's unmanageable. Hi guys, London dental nurse, Rakshay, Kat, IAS ortho, always representing.
It's all we're in.
IAS, Dr. Laney, Tina, Cameron, Tom, Ledge.
We've got a good little squad going on. So where are we working today? Because I know you're in a few different places, aren't you?
Yeah, so I was working in Wimpole Street, number 28, which is basically opposite the BDA, couple of steps down. It's I mean, very, very fortunate ultimately to work there. As you can tell, I've lost my hair because of it.
No, I wasn't going to bring it up, but Lainey's gone straight in there with it's
Nah,
coming
mate.
back, though.
Pardon?
It's coming back though.
Oh, mate, really quick.
Well, Aesthetics Awards, it was very trim at the Aesthetics Awards.
Oh, mate. I mean, it was like it was like skin. So for those that know or don't know, I obviously did it for charity. So I did a Instagram live and shaved my head for Cystic Fibrosis Trust UK. And it's funny, isn't it? Like on like things like this, like you can raise £3,000. It's unreal. It's amazing. So my wife enjoyed it far too much as well, I think. So.
Well, some of the other questions we had were about hair and beard products. So I thought maybe we won't go there.
Do you know what? Let's save that for the end because I've got that. I can reel that off, no stress.
Well, let's jump straight in then. If we can do a little just intro about yourself, just for anyone who doesn't know who you are, and then we can jump into some anterior aesthetics.
Yeah, go for it. So, hi guys, I hope you're well. My name's Shiraz Khan. I am born and bred Londoner. Studied in the Midlands, Birmingham, from 2003 actually to 2004 to 2007. I did a BSc beforehand, and then I went back in 2008 to 2013 to do dentistry. I worked in London, Kent to start with. Then I went round to Surrey because I did an SHO or DCT post, as most might know it as. And title of the topic is anterior aesthetics. And then from that, I got offered a DCT2 post, which was obviously to continue on in hospital. My social circumstances changed, and I got married. So I was really, really lucky to have met the lady of my dreams. And I didn't like the idea of living in dorms with my wife. so it was purely social circumstances that made me decide to veer off that pathway, and then I've been working in London since. So,
and you stretch over a number of practices. I know you're down the road from me in Chelsea and Fulham, aren't you? Are you still there?
Where do you work?
Oh no, I just live in Fulham.
I work
out in Reading. Yeah, I work out in Reading.
So
They are
why have you
looking
not
for
told
that.
me that before? We need to go for coffee, mate. We definitely need to go for coffee if you're down the road. Whereabouts?
Yeah. Dawes Road.
Oh, no
Literally down the
way.
road. Yeah,
Like
literally the end of the
literally,
road.
like
Yeah.
a few up. Oh, amazing, amazing.
I walked past the other day. You've got the extensions open now, right?
Yeah, that's correct. Yeah, yeah.
It looks fab.
It's really gorgeous. I mean, credit to the so the other place that I work at obviously is Chelsea and Fulham Dentist, which is in Fulham towards Parsons Green, and it's a husband and wife, Imran Saeed and Dalia Sumba, who are two of the most just fantastic people ever. They've got this fantastic energy about them, and they've basically started with a 50-year-old practice that was like a shed room basically, and now they've morphed it into this wonderful, highly classy and well respected amongst patients practice. So yeah, it's great.
Perfect. And in terms of the sort of aesthetic stuff for you, where did that interest come from? What sort of kicked that off?
Funnily enough, it started on posterior. So when I was in my final year, Lewis, a shout out to Lewis McKenzie. He's a legend in the game. He knows everything to do with composite, and he'd seen that. Obviously, hi Oscar from Turkey. I hope you're well, champ. He'd obviously seen that I had a keen interest in being able to recreate anatomy. So I was carving my amalgams like to the level that I wanted them to look like composite, obviously, or whatever. And so he pushed me into this program called the Aesthetic Special Study Module, which basically means that you really start pushing in your understanding of anatomy and how to recreate nature, mimic nature, all that stuff. So even as an undergraduate, but as I was listening to Tiff's podcast earlier today, as you know, Tiff and Zaki and a lot of people say that actually whatever you do in undergraduate, it doesn't really convert, and it doesn't really translate to what you're going to be as a clinician. So, but fortunately for me, I'd already worked that out. So I was like, yeah, do you know what? I'm gonna get into a bit of that. And then one thing came to another. Then you start, planning your CPD profile accordingly. And I got myself a camera really early on, and all of a sudden it just starts one thing to another. And posterior is where what I love doing day in, day out, and it makes up the majority of my dentistry, obviously. But anterior is what people see, so therefore you need to have a balance of being able to do both, in my opinion, frankly. So.
And Kat, the London therapist, says she's loved learning posterior anatomy from you.
Boom. Yeah,
And I
let's
know
go, Kat.
you're doing work with, you mentioned Tiff, you're doing work with IAS Ortho quite a bit. You're doing anterior posterior course, is that right?
That's correct.
With IAS?
Yeah, that's correct. Yeah, I mean, long story cut short, I've obviously done courses for a while, and getting the call from the IAS actually was kind of like getting a call from your dream job, or like the dream role that you'd want, or whatever. Because for me, they're the gold standard when it comes to ortho restorative teaching. And like Tiff's a pretty special cat. Honda Exige. I'm here to check the hair growth. Well, well done. I hope you've enjoyed it. Now you can move on. That's Zaid Fahmy, everyone. He's a fantastic dentist, obviously, because all he does is drive cars. Anyway, moving on, digressing.
No, Tiff is ace. I mean, he was on 3 weeks ago, I think. Yeah, 3. Just killer stuff.
I mean, you know what? And he's so real with it. He's not showing himself to be a certain. He's just like legend. Like, he thinks about things in a really critical manner. He's got this incredible ability to dissect things into a way that like starts seeing matrix lines, isn't it? He just sees it happening in front of him, and he's coined a lot of the terms that the world use.
Yeah, absolutely.
So he's a legend. So in essence, when he sent me a message and he said, look, I definitely I want you to get involved, and I think we can work out this. And I have obviously written up a proposal, had a discussion with them, and they were all over it. And I was like, oh my God, this is really big for me. So delighted to be doing it, running it with them, and hopefully it will go well.
Yeah, well, we had a few of the questions that we had were about sort of composite stuff, so we'll get on to that. I think the main thing let's start with is sort of consultation-wise or assessment-wise. You mentioned photography as well, and I can't remember what I heard it on, whether it was dental leaders or have you done protrusive? I heard it on something.
Dental leaders.
Dental leaders. about photography and occlusion and all those sort of things. So just run us through sort of a consultation for you and what that looks like. And are you doing specific cosmetic ones or just general that you then discuss cosmetic stuff?
Okay, so obviously patients come in, and the first thing you need to understand is what their chief complaint is. So, are they in pain? Is there any issues? If they're coming in saying, "Look, I really hate this tooth," you're already framing what you think you're going to be doing, but you're not framing what you're looking for. And I think that's the key. And I think probably this is undermentioned. When everyone talks about answer the chief complaint, it's like get it, make sure it's in the brain, and then go through your process. As soon as you deviate from the process and you start, it's incredibly difficult to turn your brain off when someone's like, "Oh yeah, I'd love the thought of Invisalign," or whatever, and you're like, yeah, and we can scan and this and that. Well, stop a second. Let's go back. We've got to check your jaw joint. You need to check the muscles. Are there any clicks or crepitus? Is there any sliding over the articular disc? Is there is there any retrodiscal tissue damage? Is there any pain on closing? Is there any pain on load testing? And then obviously muscles and mastication. Is there any pain on palpation? So start outside, obviously, asymmetries, lymph nodes, all of that stuff's checked. Then we go inside, soft tissue assessment. So everything from any Fordyce spots to any enlarged glands, whatever it is, linear, alba, bilateral on the cheeks, or like a patient I saw the other day, he's got lichen planus. He's now got an erosive lichen planus lesion on the lateral border of the tongue. So no, we can't miss that sort of stuff. Although the cancer translation rate is 0.1 to 2%, it's still a risk. So if you haven't explored it appropriately, it's important to check those things. And then I go to general, like still the routine charting. Some people like it, some people don't. I still see it as a fantastic tool. So I'll chart the teeth as to where restorations are, what's broken down, whatever. And then I go into occlusion in depth, and we look at something called the CRCP, which is the centric relation contact position. So that's the first point of contact when the jaw is closing in centric relation. And that deflective contact can create a number of problems and issues. And so once you've done, I've done BPE by then, and then I'm going into occlusion. And once you've
how
done
are you assessing that point?
What,
just
like
purely visually? The
CRCP, you mean?
Yeah.
Oh, no. So patient completely supine, the neck rest leant backwards, the jaw completely into rest, roll their tongue to the tip of their mouth, and slowly closing that plane till the first tooth touches.
And you're just visually seeing where that first point is.
Well, you ask them to put their left or right hand up, depending on which side it is. Then you're going to get articulating paper and go to that side and get just the point. Buckle mirror, retractor, photo, upper and lower. I've got a visual documentation of CRCP. And then I'll do the same, slide, and you'll see where that slide's happening. And guess what? 9 times out of 10, if there is some parafunctional activity, there's going to be a crack forming, or there's going to be a massive wear facet, or there's going to be a marginal ridge failure, or there's going to, it goes on and on and on and on. But that's something I never used to do before I started working with Koray Ferran, who's a big inspiration, big mentor to me. So I've got a visual representation of that to start with. Then I'll do X-rays or whatever is indicated. Then I'll do a full set of photographs, and that will be extraoral, intraoral, smile assessment, contrasted, occlusal, upper lower buccal segments, grinding, protrusion, constricted anterior envelope, all of those things. So I suppose what I'm trying to say by all of this is, once you've done all of that, actually, you've done everything, really. You do special investigations as per, and I don't believe in there being such thing as an aesthetic assessment. I think there's great things such as aesthetic questions as to how do you rate your smile 0 to 10? If you had a magic wand, what would you do to your smile, and all those sorts of things. But frankly, I think you should have one overall assessment that encompasses most things as you can. I understand that's not possible in every healthcare system. I do appreciate that, but fortunately you've got the luxury of time, so I want to make sure I just cover everything.
Speaking of time, typically consultation like this, what sort of time frame are you looking at?
So we have a minimum of 60 minutes. Sometimes it's 75, depending on depending on availability, obviously. But my routine new patient checkups are 60 minutes actually. And I find that's enough time to understand the patient, understand the problem, establish a rapport, critical, establish a rapport, get them to understand that you're going to do anything on their mouth that you would do on your own, and do any appropriate special investigations. Now, the only reason that I'll get them back is if you can't plan your case according to needing extra detailed information. So, for example, if I need articulated study costs, I don't think it's fair to try and just say, look, let me just do this scan and do this FaceBow, and you're going to pay this when you go outside, because I want to write to them beforehand. So I want them to have on paper, the reason I'm doing these tests is because we're planning on X, Y, Z, and what we find from these things is how it will go forwards.
And so from those points, you're writing letters for most things?
Yeah.
And you've already said you've got those photos for everyone as a blanket. And are you repeating these photos at annual sort of
Yeah. So particularly, and I learned this from Tiff actually, so he's been on a couple of weeks ago, but particularly things that you've done and that haven't gone that well, and been like, oof, right, so let me get a photo of that. Let me go and, obviously notify the patient that, this is starting to break down a little bit. But really, what you take the photo for is to look at it on the screen and be like, right, why has that happened? What's the occlusion in this situation? That tertiary anatomy, has it helped or has it inhibited the situation in this case? And, just trying to break down the processes in a digestible way. Because the problem you have, Rupert, is you'll see it for a split second and you'll be like, oh, yeah, I've got to remember that. And then the next patient comes with a massive problem, swelling this, that. It's already pushed away. You've forgotten all about it. So I think documenting frequently is how you get those long-term recalls anyway. So
yeah, no, absolutely. And in terms of then sort of your aesthetic sort of protocol, do you have a certain sort of like flow that you go through, like a hierarchy? Is it always sort of looking at whitening? Yeah. When you're honing in on a more, as you said, that patient that comes in complaining about a lateral or something, have you got a certain flow that you like to do in terms of options and things like that?
Yeah, so I think one of the main things is everyone's being assessed for orthodontics. Every patient. Tomorrow I'm going into a practice that I've actually left because I've finished her treatment, and we just got some final bits to do because it was an ortho restorative case. And in fact, I'll try and see if I can find the photos for you, because that would be quite a nice one to discuss.
Yeah, perfect.
But she came in. She's an absolutely beautiful young lady. She's a hugely successful business lady, and she's got one incisor, which is normal height, and one that's like 4 mil shorter. And the reason, and she had it rebuilt 3 or 4 times, and this last one's the one that's lasted. And I was like, oh, so she's like, yeah, this one's done pretty well, but as you can tell, it doesn't look great. And I was like, oh, well, let's have a look at that in a bit more detail. Long behold, retracted, lower incisor, constricted anterior envelope, pushing forwards, smashing against the junction. I was like, right, the reason this is happening is because the lower tooth's in the wrong position. So the incorrect shape of the upper is being driven by the lower. So if we get the teeth into the right position to start with, guess what? You're going to have a tooth that's a more appropriate height to width ratio, basically. And guess what? It won't chip as frequently, and so on.
Tiff would be so
yeah. He's in fact, he mentored me through the case. Actually, he's a legend. He's a fantastic guy. But it's the simple truth, Rupert. Like, how can you sit there and say to yourself, oh, yeah, I really like this house, apart from the corner that's sinking. Apart from that bit, yes, everything's fine. So I'll tell you what, we'll just put a couple of bricks underneath and keep it in place. And yeah, it's a dream house. It's like, no, you need to stop it sinking, don't you? You need to sort out the problem. And no criticism to the person who would have done that in the past or done it before. No criticism at all, because if you're not trained to see it, you're not going to see it. But what disappoints you a little bit is actually you've got a fantastic young lady who's hugely successful, who probably has a complex when she doesn't have to, because all that has been told is, no, that's the only way we can do it. And that's not strictly true. So I think the thing that gets me about these types of situations is that when patients are told that's all they can have and it's not really good enough, they go on trust because you're a professional. And actually that's an injustice, in my opinion. And if you
if you've got that case we can go through, that'd be really good. I think that'd be interesting if you can find that.
Yeah, I'll have a look for it.
Perfect. And I think obviously, well, we spoke about aesthetics awards earlier, more in a reference to the trim. Obviously, with that, you were quite successful in the whitening category.
Yeah,
And
yeah,
before, and a lot of other stuff as well. Quite known for sort of icon and things like that. So that was one of the other sort of questions, was sort of just icon protocol
yeah.
as well. So, but I'll let you try and find that case.
Yeah,
Um,
I'll definitely find it. I know where it is. I just need to. My filing system is about as reliable as me choosing the right color socks in the morning, mate. It's reliable. It's awful. Oh god.
And usual stuff, guys. If we have any other questions we're going along, just pop them into the comments or into the Q&A section. There is one question in there about the hair products, but I think that was to do with the profile picture from before, when it was a bit more.
When I had hair, do you know what I mean? So it's just, Rupert, it's just downloading off my iCloud. So we'll let that pan on. So we can go through questions in the meantime if you'd like. So
yeah, so I think Sox game's always strong, apparently.
yeah, fantastic.
Well, one of the other things, since we've spoken a little bit about alignment there, one of the questions that we did have was about sort of edge bonding after Invisalign. Is that something that you're doing? Obviously, you're saying more sort of ortho-restorative rather than thinking about the bonding first. But sort of thoughts on edge bonding and sort of protocols of doing that. Are you a reverse triangle, like Tiff was talking? Have you got a different technique?
Yeah, no, I mean, so really, it actually all depends, because it depends on the case. So if you've got like a massive class 4 that's going to be replaced, I'll do polychromatic layering, because that seems to work really well in my hands. I mean, there's lots of times, Rupert, where I'll even just do mono shade, because it's just very marginal enhancement of the edges. When you've got this height discrepancy, let's call it that, reverse triangle works incredibly well, because you can create translucency, and this, I'm going to say something quite controversial here, because I don't mind a bit of controversy in my older days. I'm someone who obviously polychromatic layers, right? And can you tell me what you think happens when you put layer on layer?
In terms of what, within the actual composite itself? Within
the composite, yeah.
Are you worrying about sort of shrinkage things, or in terms of actual what the end result's going to end up like, or aging of it all?
Very, very close. What I'm actually referring to is the fact of applying a layer to another layer is going to create voids within your restoration. Frankly, no matter how good you are, on a microscopic level, you're creating voids. Okay.
Yeah.
So, you know, all of these, that's why people like Magnier and Veneziani and all these people, like, they had this incredibly complicated multiple dentine shade, multiple shade in the mamelons and all this stuff. This 7-layer protocol, it ends up actually creating more risk of there being voids. And what is a void is, in essence, air. There's no filler, there's no resin. So what you're creating is a plane for crack propagation, actually. So that's the controversial bit, because if you do Tiff's reverse triangle, boom, boom, done. 2 layers, that's it. And in a way, what I believe is that the reverse triangle will be giving you a much more cohesive 2 layers, because they're flat layered on each other. When you start having oblique angles, you're going to have more voids. So, I mean, that being said, not every case is a reverse triangle. Not every case is a polychromatic layering. You have to choose in accordance to the complexity of the case. So, I've just finished that. So sorry about that.
That's all right. That's all right.
So yeah, I still tend to vary in accordance to the needs of the situation. But I think me being me, I'll always try and create some sort of incisal effect if I can. So yeah, it depends.
So in terms of, well, this case that we're going to go through now,
yeah,
I'm guessing that with that sort of amount of material, are we looking at a polychromatic sort of?
Yeah. So I haven't got, on this presentation, I haven't got the finals. I've only got pre-op photos. But the reason I think this is going to be really helpful is because it will show you what I send to the patient. So now I'm just going to try and manually sort this out. because it's going to be a nightmare, isn't it? I'm still here. I promise, still here. Right, I'm going to change my camera. Can you see the screen there?
Yeah, perfect.
Right. So I've deleted the patient name, right? But this patient is getting this case, right? They're getting all of these photos, and that's the for me. That's the critical photo.
Yeah.
You just, how is that not standing out to anyone? I mean, that tooth is smashing against that, and that has to be shorter to account for that constricted anterior envelope. Plus, you can see wear on the other teeth anyway. Come on, I mean that just you just a bit of your heart bleeds, doesn't it? Because you're like, come on, guys. I mean, I'm not an intelligent chap. That's just, you can see that. And do you know what the funny thing is? The patient can see it, right? She's telling you, she's like, oh, is that tooth smashing up against that? Oh, is that why it keeps breaking? It's like, well, if you've worked that out, there's probably 50% of the profession that haven't actually. Sorry, you can see my ring light there. So get that
getting behind the scenes now.
Yeah. You're seeing how I get my the nice composition and complexion on my skin, mate. So
how are you sending that to the patient? Are you sending this in sort of a letter form as a presentation like that?
Yeah. So what will happen is, by and large, I will have a letter that's sent to the patient, obviously, that will cover. Hi, it's been lovely to meet you at this for a consultation. You've come in because you were questioning. You had questions about X, Y, Z. What can we do about it? And here's my list of diagnoses, and this is why I think we need to do what we do. She'll get another document, so that's as a PDF. She'll get a PDF of that presentation. So it will say things like, if you have a look on slide, or if you have a look at page 30 of the photos, you'll see where your lower incisor was hitting against the upper, which is causing that restoration to prematurely fail. So it really, this whole, and Tiff, I think Tiff feels quite strongly about this as well, this whole ethical selling thing. I mean, I'm going to put my neck out there and say it's garbage, right? It's garbage. You don't sell anything, right? You have to come across as showing a solution to problems. You don't need to sell dentistry. You need to solve issues. And it just so happens that there's a financial implication for that. And I think, I think you are doing the patient an injustice if you don't talk about things like whitening, because she's probably not ever been able to whiten because she's wanted to make sure that tooth was always matched. So if you don't offer it, actually, if they turn around and say, no, blah, cool, no stress, but if you don't offer it, you're doing them an injustice. So that's not selling. That's offering a protocol that I would consider valid, given the problems that they've presented with. So your question was about align, bleach, bond. Yes, that is a big protocol in these types of cases, because frankly, if the teeth aren't in the right position, your dream house is being started with a corner of it in quicksand, or it's sinking, So I don't know. I just think that not every, but by the way, with the same token, not every case is an ABV case. I had a patient referred. She's a doctor, from someone who's in my MSc in Birmingham, and he knows me really well. He's invited me to speak at the BDA. He's such a gentleman, actually, and his wife's friends now living in London, and she was like, "No, I'll just come and see you in Birmingham." And he was like, "Look, yeah, you can. I'm just going to let you know, if there's things where you have to be in temporaries for a while, it actually gets a bit of a faff. So I'd really recommend you go see Shiraz at LCID." And he sent me a message, and he was like, "Oh, mate, I think I don't know the lady that well. I just know my wife knows her, but it's a bit of a darling bonding case, isn't it?" And I was like, "Oh, I don't know. I haven't seen her yet. I'm seeing her in about an hour. I'll send you the images." And the case is a full-blown, full 28 unit case. No question. There's no questions about it. It's not like, oh yeah, and this, and I'm going to trial the new vertical dimension basically in bisacral and composite build-ups, right? But by and large, every tooth has been worn down with a combination of erosion because there was historic illness and parafunctional activity. You know, so not everyone does fit the ABB thing, and I think again when you get a treatment plan for 28 units, whatever that's going to be for people or wherever you work, no place it's going to be cheap, right? So if I just give a print off from Exact that said, oh, here you go, you need to book in, without the letter, without all those photos, I think how is anyone going to be able to believe you? So I think we're in a day and age where patients are extremely aware. I mean, we're on Instagram now, for example, but social media has made people a lot more aware. I think that's a very good thing for the public because they can make more of an informed decision. But it's not such a good thing because they might be being falsely led as well. So I think we just need to be able to be really open about what's going on. And frankly, they can take that treatment plan anywhere and they'll be like, oh yeah, I kind of agree actually. There's not really been any oversight or whatever. Do you know what I mean?
Do you regularly take shade photos? Like
shade?
Yeah, shade guide photos, that
yes,
kind of thing.
Sometimes, yeah. I mean, I go through waves of it actually. Everyone wants a white Christmas, so I'm sure I'm going to be taking it more currently. But yeah, I think I tend to take a shade photo, but really as an understanding of where they are, as opposed to, oh, well, what was that you did? But guess what? As ironically, that question comes every time. Oh, what was that you put on my tooth? It was colour of tooth. She's like, oh, can I see it, please? Yeah, of course you can. Yeah. And I was going to put it on the screen anyway, but here you go. I was like, oh, is that what my colour is? Yeah. And where can I get to? Boom. Oh, yeah. Right, okay. It's not selling, actually. It's not selling.
Well, it's always that thing that's brought up, isn't it? That it's when a non-dentist, does a survey of patients, it's the most requested change. It's the most thing that most patients think about. And yeah, it's always what payment always says it. It's that, why would you not do it? Got to get consent for it and whatnot. But if you're doing a consultation as thorough as you are, then it's just one of the picture. It's going to happen. Why would you not?
And like I said, I think there's an element of injustice. There's an element of injustice if you're not doing that due diligence. I mean, look, let's be real about it. It's not quite the same as if you miss, OC, right? It's not the same thing, okay? But if someone is going through a process or a pathway to improve appearance and it's not discussed, I mean, that starts verging on, have they consented properly because they've had all of their options and so on. So actually it starts becoming a bit, borderline. But yeah.
And then the other thing that people want to talk about is that you're quite well known for your icon stuff and your work with DMG and whatnot. It's not something I do too much of. But can you give us a little run through of sort of icon, if you've got any cases as well? I'm sure you do, because this is in the back pocket, this one, right?
Yeah. This one I've got ready for days, mate. I've got this one ready. I'll show you a case that incidentally ended up winning. Right, so let me change this around.
This is a certified icon masterclass then.
Yeah. There you go, guys. Look. Right, so let's get this on. So
this one's permanently downloaded from iCloud, yeah.
Yeah. Yeah, this one's ready. So we've got this patient who's come in basically, and she has requested a consultation with me because I do stuff with white spots. So I was like, all right, cool, whatever. I'll do my best to help. And she comes in. She's again, very pretty young lady, 24 years old. And she was like, hi, my name's X, and I just want to know what my options are. And I was like, okay, tough case. This is not a beginner's case, by the way, just to let you know. And I went through the whole...
What about it?
Right, so that is what is not a beginner's case. That tooth right there was extremely challenging. You've got, okay, so there's multiple things here. There's more than one tooth involved. There's surface breakdown of your enamel. okay, that means that there's going to be a deeper lesion. If you were to transilluminate some of these teeth, you would see that they block out the light. So that means the thickness of the lesion is quite big, but also the depth of the lesion and where it starts is quite deep in certain areas. And the way you can tell that is, so if you look at that tooth particularly, that's got a well demarcated margin. That's probably quite superficial. That's not so well demarcated. So that's going to be a deep lesion. And that's how you start diagnosing white spots and so on. So anyway, so she comes in and she's seen someone in the West. I'm just going to turn it around for a sec. So she's seen someone in the West End. And they're like, yeah, what you need is you need 10 veneers upper and you need 10 veneers lower. And here's a bill for 50 grand. And it's like, oh, all right. Firstly, it's a punchy figure anyway. But secondly, this girl's 24. And surely you wouldn't do that on your daughter. Like, you know, I mean, I don't like reserving judgment on other people's treatment planning, because there's a reason and an understanding for both. And actually, if this was my daughter and there was nothing like Icon and she was being severely bullied, would you do something about it? Yeah, you probably would, of course. But the first thing I'd do is try and protect all of the natural structures, right? So let's go back to the case. So I was like, all right, fine. And she only told me that after we'd finished our consultation. I was like,
that's always the way. That's always
yeah. So I was like, look, there's this thing called resin infiltration. I'm not sure how well it will work because you're quite high on the spectrum of complexity. But what I propose is you see an orthodontist, because your canine on the right hand side, left hand side's in a pretty ropey position. You've got a lot of anterior crowding, and you've got this constricted anterior envelope. Can you see my colleague who's an orthodontist, and we'll get things sorted? And here's the key, you know, the importance of diagnosis. So that's the basic picture. That's it in black and white. Small modification to understand value discrepancy, and that's it hyper contrasted. That incisal edge is going to be a challenge wherever. So again, the importance of photography, you can start understanding what you're getting yourself into. So shout out to Santosh Patel, because he's provided this image, but we did some pre-restorative orthodontics, right? So what we did is all of a sudden we got to this, which automatically is a much readier, much prettier position to work with. And so one of my points on the on my stories yesterday was, what's your pre infiltration protocol? Well, first things first, Greenwall and Greenwall 2017 highlighted that your spot severity, the prominence, and the size can go down by using pre infiltration whitening. So that's one thing, but also you have to get rid of the brown spots. Yeah, those brown spots aren't going to go anywhere with Icon. They have to be white. I mean, it makes sense, doesn't it? If you want to paint a wall white, it's got loads of brown spots on it first. Get rid of the brown spots first, and then blend the rest in. You know, it makes common sense. So once you've done that, we go through whitening, and already look at the. I mean, this is probably slightly overexposed, but look how much the white spots have blended in, and actually, you're in a situation where you might be forgiven for thinking, oh, I might be all right here. Anyway, she didn't let us take her retainer off because she was extremely nervous. So a part of my heart bled when I had to do a split down. But anyway, I got over it. I got over it, obviously. And then you go through the cycles, and without getting into too much, you have to use air abrasion, because some of these areas are really quite deep. So the green gel is the Icon, which is 15% hydrochloric acid, which on average will reduce the enamel by 27 to 49 microns per application for 2 minutes. You'll do that on repetitions, and you apply the Icon Dry, which is 99% ethanol, and that gives you a test drive of what it will look like when it's infiltrated. And as you can see, that tooth still is a bit of a problem. Yeah, even a lot of the others are. So we went through, I think, 10 cycles, 2 cycles air abrasion, until we got to the point where, can you see that? It's starting to blend a lot more. And then I got to this final point. I was like, oh my God, we've done it. We've cracked it. We've cracked it. There's no more mottling underneath. We can go to the full blown thing. So you infiltrate. So what that means is you apply the resin infiltrate, which is Tegma resin, pure Tegma resin. You're going to apply it on as a scrubbing motion for a minute, and then you're going to allow it to stay and infiltrate for 2 minutes. So any direct light needs to be removed. You need to floss in between the embrasures because you don't want resin getting caught there, and you're going to cure it, obviously. Each tooth, and this is really critical, each tooth for 40 seconds, not 20. It's not composite. If you undercure it, you'll get discoloration, absolute discoloration. So then you reapply the resin because there's high contraction shrinkage because there's no filler, and then you recure, again, same 40 seconds. And that's what it looks like immediate post. Immediate post. Yeah? All white spots are gone. But what you'll notice is there is some scalloping or concavities. Yeah? There's some concavities because I've created erosion defects. So, and that's the difference. That's why I've had to use composite. So I haven't sat here and just composite veneered the tooth. Yeah? Like everyone else. I've just put it on the places where there's erosion defects. You spend some time polishing, and that's where the patient's at.
Wow.
Yeah. Pre, post, pre, post. And a bit of tomato on the review because I was so excited I forgot to ask her to just flash it away.
How much does that wind you up?
Mate, it makes a story for every time I share it. It makes a story for every time I share it. And look, here's a 1 year recall without the smartphone, obviously. And look how good it's looking. Look how good it's looking. It's almost like it's getting better with time.
So what typically is your sort of lifespan on the Icon?
So I think that's a great question because I don't think there's any evidence out there to prove against or for it, actually. I think Icon is a fantastic tool, but it is actually in essence a composite or a less it's a less strong composite, obviously. And the way it infiltrates and the way it integrates into the tooth substructure, the enamel, prisms, etc., it's very, very closely adapted. So the reason they chose Tegma resin is that it has the highest penetration coefficient of all of the resin and resin combinations. So it has the most wetting and it penetrates the most deep. So invariably, this case is now going on 5 years and we haven't had to do anything. So my point is here, maybe that 50 grand plan for doing veneers on everything, maybe that's going to be applied at one stage in her lifetime. But I'll tell you what, I feel a damn sight better if I'm doing that when she's 50 than when she's 24. So it's just trying to get outcomes that you're trying to live with, you know, and something that you're happy to do for someone that you do on your own family or your own daughter. So,
well, that's what we sort of frame this one as, was as minimally invasive, and that's the classic thing that, you know, you learn at uni. You learn that sort of bleach, resin, braid, resin infiltrate, composite, porcelain. You go through that sort of protocol, and as you say, at some point, porcelain converting to porcelain, maybe better, as you say, those wear cases, even potentially where you're doing initially posterior units and anterior composite, you might be, you know, transferring those into porcelain at some point as well. It's just going down that cycle, right?
And I think there's something, because this is really quite important. Minimally invasive dentistry doesn't mean you don't invade one, but more importantly, minimally invasive doesn't mean that you leave stuff, right? So I'm not a minimally invasive dentist because I don't treat wear. Like, you know, that doesn't make any sense. It's, if there's a need that presents itself, how can I respect the biological structure sufficiently to still provide an outcome that's going to improve health? Do you know what I mean? And I think sometimes people are like, oh, I didn't drill that there, or I didn't do this because I didn't want it to remain minimally invasive. No, it doesn't mean that you get a suboptimal outcome. That's not what minimally invasive means. So I think just doing your best, isn't it? No one's gonna, you know, die if you take take an extra 0.5 millimeter into a box because you're worried about if there's caries or not. Break the contact point, understand where that's at, and create a more functional, harmonious cleansing pathway for in between teeth. You know, that's why I don't really understand those really small box preps.
That's always Celine with when I'm working with Celine. That's always her thing is minimally posterior. Obviously, posterior cavity prep's her baby at the moment, but yeah, it just not doing it correctly isn't, just because it's minimally invasive isn't really right at the end of the day. Mike Gray's had an interesting question there, which I was going to go with as well, is have you ever had to whiten again further down the line, with the whitening obviously fading over time? And how does that go with it?
What was his name? Who asked the question?
Mike Gray, it's just the bottom there, Dr. Mike Gray.
Mike Gray, I hope you're well. That's a fantastic question. Yes, so what I tend to do, because your resin infiltrant is now a barrier, and that barrier has been shown to be 12 to 17% more resistant to acid attack and carries progression. So you have sealed off the tubules in essence and the enamel. So what I tend to do is I do palatal whitening. Yeah. So I'll get whitening trays with palatal spacers and they'll whiten from behind. This was pioneered by a group, Paulo and colleagues in Brazil, for those who had veneers, and their veneers were obviously ultra thin, but they were starting to discolor because the tooth behind was discoloring. So they just started whitening from the back. So when I found that out, I was like, oh, right. So guess what? That's going to be my solution for resin infiltration. You just whiten from behind, and it should be fine. Because it works by diffusion gradient anyway, isn't it?
Perfect. Because that was obviously the one thing that will change over time, whether it's the icon degrading is going to be the whitening that you've done before. The other thing that people want to know in terms of composite stuff, and we sort of touched on the polychroma stuff, is about selecting shades for dentine, enamel, blending that together. Mike's happy with the answer to your question there. So sort of shade selections and things. Are you a composite blobber? What's your sort of protocol for that kind
composite
of stuff?
blobber? If I was Mr. Blobby, I would have loads of composite shades on me. So that's probably the best compliment I've ever got. I think there's lots of ways that you can do it. It all depends on how it works in your hands. Okay, so there's two things. Rupert, I tend to go off on a tangent, so bring me back to the answer. Okay.
All good.
So the first things first is with anterior composites, I think people are slightly obsessed with shade when they should be obsessed with primary texture or primary anatomy. Yeah. So get your line angles right, get the texture correct. The macro texture, not the micro, just the rough texture of the tooth, where the line angles are, your embrasures, how they change from the mesial to the distal, how they change from the 1, 2 to the 3, those sorts of things. If you can get those right, even if the shade's wrong, it automatically will do pretty well. So that's the first thing. In terms of shades, I try to do the composite blob technique actually at the beginning of every appointment. If I was to do, I'm going to put my MSc hat on here and say, how predictable and reliable is that? Because the patient's probably coming in, they're probably quite anxious, happy or sad about what they're going to go through. They've probably already got a bit of dry mouth. They've probably already had a bit of dehydration of the teeth. So when you're doing it on the day or even on an appointment before, how much rehydration or dehydration effect has already occurred? I don't know. Vita shade guides, I don't necessarily believe in, although I use them for whitening, because they're acrylic and they're not a representation of the material you're going to be placing, and therefore I don't think that they give an accurate representation of what you're going to be recreating. But yeah, I think the most accurate way is either make custom-made shade guides or the composite blobbing technique, because at least you get a real-time opportunity to take the shot. You know, that blah 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 done shot, and you can just pick the most ideal. It's probably ideal if you do that on a separate appointment, but I understand the economics of that not being quite viable at times. So because you can't see if they're doing their whitening, you can't see them immediately after they whiten because there's going to be a rebound effect. So you don't really want to pre-guess, and it can be a little bit, the science of shade taking can be a little bit difficult. There's some fantastic tools actually where you can just take photos with grey cards and stuff, and you can calibrate your photo to work out what the best shading will be. There's even apps with a little microscope that goes over your phone that you can read the shade of the tooth. I mean, the Trios does a fantastic job of picking up shades now. It's incredible. There's loads of things on our armamentarium.
And when you said custom guides, you mean creating one yourself using, D2, A1, blah blah blah. Yeah.
Because the amount of variation that you can get is quite substantial. And as you know, for those that have taken shades, interest in shade taking seriously, the thickness of your material will have a huge impact on the hue value and chroma of the restoration that you use. So I try to avoid my enamel thickness being more than 0.5 or whatever system I'm using. that doesn't always work out, obviously. So you just have to try and manage that sometimes.
We've just had another whitening question pop up. Gareth the dentist. Great talk, guys. I'm struggling with he's struggling with an internal whitening case ongoing. Any tips for internal whitening? Do you do a lot of it? Is it something you give to the endodontist?
Yeah, no, I do it. I like trying to be conservative with my preparation. So, what was the chap's name?
Gareth. Gareth the dentist.
Gareth, I hope you're well, mate. Thanks for tuning in. Right, so Greenwell and Greenwell Cohan, 2019. Boom. Just off the cuff, mate. Got it for you.
Loves the whitening references.
Yeah. Well, I've got more, man. I can give you loads on Icon as well. So, Greenwell and Greenwell Cohan, 2019 BDJ paper, whitening of the non-vital tooth. So they say in the paper, the number one reason for external whitening not working is incomplete pulp chamber removal. Mm-hmm. So you've got, if a tooth had trauma, bilirubin or any of the heme products have basically splurted out and they've embedded themselves within the dentine. That's one of the major reasons why you might get that. I now opt for the inside-outside closed technique. So I'll obviously seal off the GP appropriately, make sure all the internal pulp remnants are gone. I aerate the internal surface, and I'll also etch the surface as well, because I want to increase the permeability. And then I will leave 10% carbamide peroxide in the tooth and seal it off. I have a tray that's made that's got buccal and labial spacers, and I will get them to whiten that single tooth for a week at a time. Mm-hmm. So it saves all the faff with injecting into the back and this, and there's got a bit of chicken when they come in the next week and all of this stuff, like I don't want to deal with that. And also there's far more chance that you can go wrong if you leave it that way. And I've got a case that can demonstrate that. Actually, I'll show you in a sec. And you'll be so surprised at how much of a result that you can get by making sure that you've got complete pulp removal.
Yeah, so, I've always done sealing it in.
Have you?
That's how I've done it. Yeah, purely from again, I just don't trust a patient to keep it really tidy and get it all in there properly and keep it. It just doesn't make sense for me. I know you sort of glossed over it quite quickly about the preparation. But just run us through a quick little bit about that. You said aerobrading, things like that. How much GP, 3 mil, sub CEJ, is that what you're aiming for?
Yeah. So, right. So that I mean, obviously there's quite a bit of science behind that. So 3 mil sub CEJ is ideal because the other reason that you get it reddening or near the neck is because the GP is too high up. So you need to get rid of that, obviously. I tend to then go in with a rose head and try and see if there's any softened elements of caries dentine or anything that's left, but at relatively low speed. And I'll just gently graze the inside of the chamber because I want to be able to lift off anything that shouldn't be there anyway. Air abrasion's fantastic because it lifts a lot of stain. So if there is stained dentine, to drill it away, it might be a lot more aggressive. So air abrasion's going to remove that. Then I'll apply phosphoric acid on the internal surface to try and open up the tubules, mm-hmm. so that you're going to allow for perfusion in and out, in essence, to those areas. But yeah, 3 millimeter sub CEJ, etching inside along with air abrasion, and then sealing the whitening train. The gel in. Incidentally, I have done open and closed, and I have had pretty fantastic results with it as well. But you're right, the faff with it is just. It's just at another level. I mean, you just can't. I just don't feel okay leaving something open in the body. Do you know what I mean? It just doesn't sit well with me as a principle. So,
Mike Gray said the same thing. Leaving it open is like driving your convertible through the car wash with the roof down. It's effective but messy. So yeah,
that's a fantastic analogy. So I've just got this case quickly that I can show you. So this patient obviously comes in and has got that sort of thing going on. And I've even got the sequential photo. So week 1, week 2, week 3. Mm-hmm. And the key in that case was ensuring that I'd had complete pulp horn removal, and now she's like completely over the moon with it, you know. So
in terms of pulp, you're saying pulp horn removal as well, in terms of just opening, flaring it out a bit more, clearing that sort of, well, it's not, the labial facing surface of the pulp chamber as well. But mostly closed is what you aim for.
I try to now. I think it's probably much more. I think it's much more predictable, actually, is what I'm getting to, because I think having gone through the cycles, and you know, like you're not going to get like hydrogen peroxide go down the throat. You know, like there's just too many variables. You're right. It's like driving through a car wash with a convertible. It's like, well, if you don't like your car, go for it. I mean, but yeah, that's a great analogy.
Yeah, perfect. Well, I think we've covered all the sort of questions that came up from before, and hopefully, Gareth, that covered it for you there. If we have any other questions, guys, please do chuck them at us now. Otherwise, I always like to ask one sort of thing towards the end, which is like a top tip for young dentists, or what's something that you do now that you wish you were doing earlier on in your career. Is it looking at the occlusion the way that you do? Is it the photography you do? Any kind of tips like that?
Yeah. Firstly, I want to say a massive thank you to everyone that joined. A massive thank you to you, Rupert, because obviously you're doing some fantastic stuff, and it's lovely to see that you're using such platforms in the way they should be used, and spreading positivity and education, and not just doing it because it was a COVID thing. You know, I think it's very, very credible that you're still doing it. So thank you so much for the invitation, and keep up the great work. Secondly, to all young dentists, get a camera. I mean, that's just changed my practice inside and out. Try and find that CRCP for every patient after today. Try and find it on everyone. Not even because you're going to do anything about it, because 90% of the human population have a CRCP slide and it doesn't cause any damage. But guess what? If that's the crown that you're replacing, yes, it won't last. So I think I'm just trying to share that bit of knowledge, because actually I have put in restorations that have been a CRCP interference, and only realised in 3 months later, be like, oh well, God, that's great. Well, I've done that. What am I going to do about it now? If I equilibrate and they slip further back, they're going to smash that restoration even more. What do you do? So understand occlusion to the level that's predictable, safe, and if you are going to move teeth, understand that you moving them in space is going to have an impact on the ability to have anterior guidance, balanced protrusion, no posterior interferences, whether canine's guidance has remained or not, whether that's beneficial or not, non-working side interferences, all these types of things, because orthodontics is a fantastic tool for us to protect people's teeth, but it can also be the tool that creates demise if we don't do it properly and we don't assess it properly. So I think occlusion is really, really important, but get yourself loops, get yourself a camera, get yourself on a course that outlines what you want to do, and set yourself targets, set yourself goals. So in 1 year, I want to be able to do X well. In 3 years, I want to be at Y, and in 5 to 10 years, I want to be at Z or beyond. And if I believe in the infinity rule, in the sense that you shouldn't put a glass ceiling above yourself, but at the same time, why not make your goals infinite? And this is a criticism to myself more than anyone else. Just don't get caught up in the rat race, and the rat race might even be your own rat race. Be able to enjoy the journey, because I think if I was going to reflect on my career, even though it's very short, I haven't had time to enjoy it as much as perhaps I want to, despite of what it looks like on social or whatever, So I think that the amount of work that goes into it, this week, I haven't got home before 10 o'clock this week. It's just is what it is. So yeah, just work hard and play hard, I'd say.
Perfect. Well, I won't keep you too much longer, Ben. In terms of, we mentioned earlier the IAS composite, upcoming courses on that. When's the next dates for those?
Yeah, so we've got a date for the 5th and 6th of November. It's a Friday, Saturday. It's the first time IAS are offering posterior composite. Yes, the one. Oh, what's going on, Mr. Dr. T? I hope you're well. The fantastic thing for me is that we're going to be covering posteriors too, which is something that's close to my heart. And IES understand actually that ortho-restorative means stability and posterior occlusion. So, you know, trying to understand the anatomy, why it was done that way, where your centric stops are going to be, you know, all those sorts of things. How to pre-assess your cavity before you drill it, you know, all those types of things. And I mean, if anything that you, I mean, I've very, very hastily tried to get things up for you today, but you know, we're going to have a very, very thorough program that's packed. And if you need any more info about it, just go to isortho.com, I think, and go to their courses.
Perfect. Awesome, my man. Thank you so much for this. And I'll let you get going. Cheers, everyone who stopped by. Next week, Thursday again, we've got Chris Barrow coming on. We're going to do some business stuff. We're going to go non-clinical for a change. So I'll see you then. Cheers, man. Cheers, and I'll see you for coffee down the Fulham Road.
Rupert, I look forward to it. Make sure we do that, yeah?
Let's sort that out.
Cheers.
Cheers. Bye, guys.
Cheers. Bye.